Beginning now in the panel room, the panel discussion on Beyond Billing inside BH Revenue Cycle Strategy, moderated by Harry Nelson.
Yeah. Should we get started? Okay, perfect. All right, great. Thanks everyone for being here. Hopefully we'll have some more people walking in. Great to have we have a great panel today. This topic today was titled Beyond Billing, inside a behavioral health revenue cycle strategy. And my hope is we have in the next hour, our goal is to do just that, to go beyond sort of the nuts and bolts of billing and really get into how to think about this, how to move your organization forward in behavioral health. We kind of divided the topics to three kind of headlines, and I apologize in advance that we won't have time to go into as much detail as we'd like for all of them. Just a moment to kind of take a snapshot of where we are now in the eyes of a great panel that we've got that I'll introduce itself in just a second. Second, to get into the topic of relationships with payers, what not to do to erode them and undermine them, what to do to build them, and finally getting into the value of revenue cycle dashboards and metrics. So with that, I'll kick it off. My name is Harry Nelson. I'm a healthcare regulatory lawyer, and I'm actually excited to have a panel that's much more in the nuts and bolts of doing this. I give a lot of advice on what to do to avoid trouble, frequently like when things start going wrong in payer relationships, but I'm very excited to be moderating today. I'm going to turn it over to Harrison to kick us off and introduce the topic and talk to us about also not only who you are and what you do, but your relationship to this topic.
You got it. Appreciate it. Thanks, Harry, for the introduction. So I'm Harrison Katzen. I'm one of the co-founders and partners at Zinnia Health. We are a national behavioral health operator. We currently operate in 6 states and expanding. We have 10 inpatient locations, 10 outpatient locations, around 1,000 employees. We treat around 10,000 patients a year, primarily SUD. We also treat mental health. On some of the topics that we're kind of going through today, I'm probably going to focus mostly on the revenue cycle management of what an SUD provider goes through. I'm going to talk a little bit about the challenges that we've seen over the year of 2024, some of the recommendations that I would make to provide stability to your organization as you look at payer relations, what your mix of your model looks like, and ultimately how to be able to predict your cash flow cycle. So appreciate it. Thanks, Eric.
Thanks. James.
Hi, I'm James Craig, and I'm a former payer. I've worked for 25 years and managed behavioral health care. The last 10 years, I've been exclusively devoted to autism and ABA. And so I have an understanding of kind of both sides of the equation, really. And so, my work has been with autism payers, providers, and platforms in terms of helping them understand some of the critical things that need to be in place to provide quality care and to recognize quality care. And so probably one of the things that I would focus on has to do with information and data gathering and being able to put that together in a profile toward having a preferred relationship with a payer.
Thank you. Scott.
Yeah, hi everyone, I'm Scott Delmar. I'm with Congress RCM, and I've been in the field for about 15 years. Trying to hide the gray hairs to show, but get reminded. And first half of my tenure was primarily third party. I served as an outsourcing option. Then the latter part of my tenure, straight RCM consulting. So what that means is anyone that's looking to be educated on it, anyone that's looking to increase their revenues without necessarily having to increase their census, that is what we specialize in. What I'll be touching on is a little bit of everything, but especially the dashboards. RCM dashboards is going to be a fun one.
Greg.
I'm Greg Kalin, co-founder of Prosperity Behavioral Health. We're a national third-party revenue cycle outsourcing services firm. We're a technology-enabled business. We focus a lot on data and using data to drive not only our internal operations, but also to advise and support our clients in their growth. And so what I'm going to be talking about mostly with respect to this topic today is going to be how to integrate RCM into a broader performance management strategy for an organization, and use the data that's generated by the RCM activities to actually influence operational behavior and improve financial and patient outcomes.
Terrific. So I wanted to start us off, we'll come back to this slide actually in just a minute, but sorry, with the question, with this first topic of, is this gonna work? With like what we're seeing right now, and I guess I'd like to maybe put each of you on the spot to tell us a topic that seems to be a challenge of the moment with regard to revenue cycle that's on your mind. Harrison, can I?
Yeah, so I would say in 2024, the year for us just being a national player was out of network and maybe third-party provider repricing. UHC just being the big one. What we saw with United is that they started to use TPA, TPP, as a lot of people know. They went to Vine and Navigard. They were previously reimbursing at rates of, let's just call it $1,500 to $2,000 a day on the out-of-network. And then they started to reprice, and we started getting paid $677 a day.
By the way, do people understand what repricing is, or should we take a minute just to talk about, do you want to explain what repricing is?
Yeah, I'm happy to talk about the repricing, but basically it's a tool where the carrier decides to use a third-party administrator, and they use them to their benefit to work on the behalf of the patient to reprice what they are actually paying out previously from their previous claims. So if you went directly to them, they would pay a certain rate. As long as they use a third party, they're now repricing, as we say, to a different rate. They didn't disclose that to us. That was the major kind of issue that we went through. And so, you know, you're 90 days in arrear, 120 days in arrears, trying to figure out what's going on. You're calling everybody, and then it slowly starts to kind of trickle into the market. Hey, you know, UHC started to use Vine and Navigard, and then we're kind of, you know, on our heels trying to understand what to do and how to move forward. So that kind of answers the repricing for you. Does that make sense?
Yeah.
Yeah.
It's a big topic I think we should come back to, because I think it highlights the question of understanding what's going on in terms of why you're getting the amount of money you're getting and who you're dealing with on the payer side.
Definitely.
James, can I put you on the spot? What's on your mind?
So I think the concern in the beginning, when the autism benefits were rolled out and were approved for Medicaid and also for commercial and state mandates, the concern was on the part of payers that this was going to be $1 million for every case. That didn't happen, and part of the reason for that is that that wasn't going to happen because of the way that rates are structured. But the other part has to do with the fact that there were so few BCBAs. And so there was a limiter in terms of the amount of treatment that could actually be provided and the supply, actually, of providers. In the last couple of years, certainly in post-pandemic, there's been, I would say, what I would consider a mushrooming of utilization. You know, people now know where to go to get a diagnosis. They know now where to go for providers, provided that they can get in and they can secure an appointment. But, you know, these are cases that require 20, 30, 40 hours a week of intensive therapy, and that turns out to be expensive. So one of my concerns at this point has to do with there's been some issues in the Medicaid area, particularly where a provider, or a payer rather, has begun to put limits on the number of hours, is getting more aggressive about utilization, is excluding providers that they consider to be outliers. And so that's on the Medicaid side. That's a new feature, and one has to wonder if that's something that will be picked up over on the commercial side and by other Medicaid payers, because those things have a way of happening.
Thank you. Scott.
If we're speaking about what providers should be paying attention to, should definitely be their revenue streams. I think gone are the days where, you know, really substance use treatment program can just rely on really levels of care. Now that needs to be supplemented, augmented with ancillary service, especially really telehealth, right? That's a big one that everyone should be focusing on. Another one is the outpatient services, because there's a need for it. So your groups, your individual sessions, And really mental health, if you're primary SUD, you absolutely should be looking at incorporating a mental health program, mental health track, and even payer mix. Like, I know it's kind of weird timing to say this, especially what's going on in the political landscape, but if you're primarily commercial payers, you definitely want to start to look into Medicaid and be able to save more lives there, help more people there, because we have some great geographic areas where Medicaid programs do really well. So that would be my 2 cents.
I want to come back to the Medicaid, a couple of things you said, but Greg, what's on your mind?
I'm going to cheat a little bit and give you 2, Harry, but I'll be quick. One of them is the continued shift, especially in the SUD landscape, towards in-network prioritization around the payer mix. For valuation and risk reasons, among other things, we've definitely seen over the last couple of years, many of the folks that we work with are moving more and more towards either majority or exclusively in-network payer mix. And then on the other side of the coin, for those who are in network, one of the things that we've seen in the last year or 18 months that has been a challenge for some of those folks has been some of the network narrowing that some of the payers have done. And folks who thought they had access to a pretty broad base of patients because they're in network contracts have all of a sudden found themselves excluded from some of the networks under the contracts that they had originally signed. And so that's been a challenge that our in-network partners have had to navigate.
So I think that'll be a good lead into our next topic. I just want to add personally, you know, the thing that's really worrying me these days is in the post-pandemic period, if you think about a lot of this, there was really a reset on behavioral health insurance coverage and reimbursement, as well as Medicaid with the Affordable Care Act. So we're not quite 15 years in, and in the post-pandemic period, the demand across the board, autism, substance use, mental health is just surging. But it's you know, Scott, to your point about Medicaid, it's a worrying moment about what the Medicaid budgets are going to be and to what extent the payers are going to flow off of it. And I wanted to pick up, I think it's such an important point that you both alluded to, which is diversifying your payer mix and not, you know, as a lawyer, when I get somebody who's got a problem with a payer, if that payer represents 15% of their, you know, of their total mix of clients, of their patients, it's a problem, but it's a manageable problem. If it's 85%, we're talking about life and death for the program. But I want to, in the interest of time, I want to move us forward to this big topic, which ties into the networks and how do you build relationships. I find so many providers, I'm violating every rule by, I thought I'd silenced my phone and you're getting my ringtone. Anyway, and by the way, we could spend all day on any of these topics, and I hope people will follow up with all the panelists because there's a lot to say about all of them. But I really want to get to this core topic of relationships with payers and how hard it is. I think we have largely a provider audience here at BHASE, and I'd love your thoughts, and in no particular order, so feel free to jump in about what people should be doing and not doing in whatever order, and how you think about what it looks like to build a good payer relationship.
Maybe I'll start
Please.
as an operator. So I think there's a couple different thoughts. If you acquire a business, you're acquiring some legacy elements to it, which you just don't know about. So what does that payer relationship look like? Did they have a bad reputation? Are you just not going to get the reimbursements that you expected from some of the practices that they did previously? So that's in an acquisition world, so I think you probably want to get your arms around what that looks like, because agencies, operators, we have reputations amongst the insurance companies. So if you're new, they don't really know you, they're evaluating you. If the business that you acquired has been in the space for a period of time, they definitely have a reputation, whether they tell you that or not. I've personally experienced that with some of the acquisitions that we've worked on. I think for de novo, you got to think, maybe what does the insurance company want at the end of the day? And I'll speak specifically to SUD and then mental health. So for SUD, they don't want them in the emergency room. That's like the one thing that they want to keep out of. That's just a huge cost structure for them. So when they look at us, we're supposed to really provide a good product, a good service, and you want to minimize the long-term, very large expenses that they're going to see on that individual member. So how do you do so? It's probably really, showing that you have a good product at the same time. And so that kind of comes in with your utilization review team, making sure that your notes are really good. having a QA team behind that to make sure that, hey, we're one of the good guys, we understand what this looks like, what does the ASAM fourth dimension look like, how are we kind of notating across the board, and then one of the other big points is outcomes, showing them positive outcomes and communicating what your outcomes are. If you're showing them that, hey, this is what happens to our milieu, our patient base at the same time, they're gonna have a different level of respect, but you gotta communicate with them. And that happens from your individuals in UR to your billers to your director of RCM, whatever that looks like. Those are really serious conversations that I would just say reach out and start to have those conversations. You would be shocked and surprised how many people inside of the insurance companies want to help our patients. It happens all the time. I call them randomly. It's not my job, but as one of the equity shareholders, it's something that I'm interested in, and they're happy to talk to you, but you got to make sure that you have a good rapport with them at the same time. So those are just a couple of thoughts I would say as an operator, what I would look at. Yeah,
well, in autism, on the payer side, the anecdotal information had to do with does the provider return my phone calls if I have a question? And, are they individualizing care, or is every single treatment plan coming across my desk look identical, right? Except for the name of the child. So now I think that it's to the point where it really is important that the insurer or the payer understand you as a differentiated provider. And by that I mean that from their point of view, it has to do with the total claims and the number of people that are being served. That's the readily available information for them. But what's important is that they understand, the metrics and the performance. And I really think that, and we're going to talk about this later, I think, it really is going to be more of a pay-for-performance kind of scenario than it has been. And so there are, at Beacon, where I worked, we put together, I think it was like 6 indicators, and they had to do with things like access. It had to do with things like, are the parents getting involved? Are they involved in training? These were, and I think we had a slide for that, actually.
Oh, yeah, I can.
The next one, I think. Yeah, there we were. So, this was just a really kind of rough cut. Access, the dosage, the weekly amount of supervision, the weekly amount of monthly parent training, and so on. Where is the place of service happening, and the length of stay compared to the network. So those are some of the things that we were able to bring about. This is all can be derived from claims, actually. But beyond that, I think what we're recognizing is that providers also vary in terms of culture. And so, when you look at things like turnover, for example, that's a proxy for, a lack of continuity that's going to be happening for a family and for a child. So this is a very elemental dashboard. I think there's about 20 indicators I think that payers would be interested in learning about. But it will be in terms of differentiating your practice based on your performance.
Yeah, so I'll jump in now.
Please.
All right. I just wanted to make the eye contact. Don't want to violate. So I want to go back to what Harrison said, right? So let's kind of put a reminder on that. His key terms were long-term costs of what the member is, and then really collaboration, right? Meeting with the payers, showing them outcomes, all that good stuff. Another key term I would like to add to the mix is leverage. You have to have leverage, right? So that conversation looks completely different than someone going on the website, finding the number, speaking to provider rep, and just putting in an application blindly. Opposed to you understanding the power that you have, which is how many lives are you managing, how many lives are you helping, reducing that long-term cost, emergency room, other medical visits, everything, and being able to come to the table to say, hey, there's a clear path, right, to lowering costs on your side, so we just want to get fairly compensated as an operator. So that's the only piece I would kind of add to that.
I'll pick up on a couple of things that folks have said in the last few minutes. One, on the topic of leverage, another thing that we talk about a lot with the providers that we work with. We think about payer relationships on a spectrum where you've got a macro perspective, which is how does your organization relate to the payer from a contracting perspective, and then at the micro level is how does your UR rep talk to the payer on the phone when they're on the phone with another human being trying to get care authorized for a patient. So in the macro perspective, on the topic of leverage, another thing that's really important to think about is sort of demographics and geographics, right? So if you're in an area that is underserved, if you're delivering care to an underserved population, if you have a program that's focused on a particular group of folks, that's an advantage. That's an opportunity to engage in a constructive conversation with a payer. Yeah, they've got folks, they've got covered lives in this remote geographic region where you're going to put your facility where there's no access to care for 3 hours in any direction. That's a really important program for them to have on their panel. As opposed to if you're putting a 6-bed detox in Southern California, they're less likely to be excited about that. On the other end of the spectrum, in the micro level, one of the things that we often talk to our facility partners about is, as Harrison said, you have a reputation. And that reputation can be good in the sense that if your charts are good, if your UR reps are reasonable, if you're asking for something that makes sense for the care, you're going to get a good reputation. And you're going to get a lot of leeway, or a lot more leeway with the case managers. On the other hand, if you take everything to peer review, every single case, then the case managers are not going to like you very much, and you're going to have a lot tougher time when you really do need those extra days to keep that patient safe, to get them on the right path to recovery. So I think there's really two ends of the spectrum that you got to think about at the same time.
I had a couple of questions. One question I have, a lot of times people will ask, who should I be talking to at the payer to build a good relationship? What does it look like? Does building a relationship literally mean having a dialogue, or does it just mean making sure that your records are tight and you're paying attention to data points like James, you were alluding to on your slide? What does it actually look like to build a relationship? Where does that happen? How does it happen?
I would say the best place is the day-to-day. Like, that's the open that you have. You're communicating with that carrier who is driving your revenue. Make sure that your team is reaching out to them. I mean, you see it happen all the time. They have to be able to correspond. I see the emails that go back and forth if there's an issue, if they want to deny a peer review, if the CM wants to kind of get additional information on the medical records. You'd be surprised how you can open up relationships by just communicating with them at the lowest level. I think there's other strategies, LinkedIn, coming to conferences and all that stuff, but I really like the grassroots approach. I think that's kind of where you're able to differentiate a little bit, and you'd be surprised at the doors that open when you're just doing it on a day-to-day basis. That's where we found our best relationships that I kind of now have come from just a random email where I've asked somebody to make an introduction, and we've talked about it, and then that's kind of dovetailed and blossomed into a really good relationship with that payer. So that's been my experience.
I was thinking as you were talking how it makes sense. The problem, a lot of times, by the time people are coming to a lawyer, they're talking to special investigations units, right? And those are not the people you want to build a relationship with.
Right.
So, any thoughts, James?
Well, I would agree, day-to-day is important, but I think as we talk about things like contracting and creative contracting and so on, I think it has to go up some levels, actually. And it is very difficult at times to find out who within a payer organization you're supposed to talk to. Most of the time they'll tell you talk with your provider relations person, but that doesn't really get you where you need to be a lot of times. And so you may need to go up the chain. You can talk with the clinical director. You can talk with the director of credentialing or the director of contracting to have these kinds of discussions. Because a lot of times if you're talking with the customer-facing person, you're really not probably going to have a desirable result.
That's a great point. It does take a little bit of work to figure out who's in charge of what, who's in charge of policy, but it's definitely important. That's a great point. Any thoughts?
Well, I would say the quickest path to catapult straight past that gatekeeper, who's the provider, right, is leverage. You got to go back to leverage. From the payer's lens, it's a cost, and they want to contain the cost. So if they see a provider that has an ability to contain more costs, then you don't have to guess who you have those higher level conversations to. You're going to get pushed there, right? Just based on volume. So I would say it ties back to leverage, and that will make your life easier. Now, the day-to-day operate everything, yes. But if we break it down to the fundamentals, it's a cost for the payers, and it's cost containment, and then the leverage piece sits on top of that. So all my larger enterprise clients, they don't have that, guessing game. Who do we speak to? How do we get on plans? They actually get routed there.
I think this is also a case of it's not what you know, but who you know. I think there's a really good argument in a circumstance like this for outside help if there's somebody who really has that network of relationships, who knows who the right people are, and is able to sort of short circuit around that sort of searching and whack-a-mole process. I think this is one case where there's a really great argument for bringing in some outside help. But I do really agree with Harrison that once you do get to that right person, they're going to look at your file, right? The payer is tracking you. You have this reputation with the payer. And if you've not been doing the work at the micro level, it's going to make it a lot harder for you at the macro level as well.
Any thoughts on mistakes that that providers are making that are undermining trust and relationships with payers?
I will say the one that's already been mentioned a few minutes ago is chart quality is a really big one. I mean, it is one thing to have all of the dimensions in your charts. It's another thing for them to be personalized, right? Like so much copying and pasting still happens in the field, not because of any ill intention, but because it's a lot of time. It takes a lot of time and energy and expertise, frankly, to document really to the payer standards. So I think that type of thing is a really easy way to trip over your own shoelaces when you're sort of at that ground floor starting to build that relationship.
Yeah, it's a great point. By the way, I made the point, but I really think it's important. It's the depth and the actual detail so that every patient doesn't look cookie cutter, and also the organization so that payers don't have to stumble through and figure out how you've organized the material.
I have a question for either Harrison or Greg, like just a conversation around that. How do we think AI is going to impact that cookie cutter component? Because I know it's a big push for that right now. But
I think you took the words out of my mouth, but I think the thought that I've been thinking through, because you had like a smorgasbord of answers, I was saying operations gets you to that, point. James is like, hey, it's the key decision maker. So it's clearly, that element, the key decision maker is probably where you need to go, but how do you get there at the same time? I think the big thing I would think about is if you've been operating in the space for a period of time and you think that what you were doing back in 2018, 2019 is going to service you today, you are sorely mistaken. We went through a COVID period. There was understaffing from what we saw. You were able to probably have not the best charts, so you just got away with it. You were lulled into complacency, thinking that was going to be okay, and then AI came on the back of that and hit everybody like a hammer. And so that's kind of what's going on right now. So if you don't have best-in-class charts, if you're not creating individualized treatment programs, if it doesn't seem like you're seeing the best-in-class primary care physician like you might see when you try and go to someone to take your kid to because you're worried about it, if those aren't happening for all of your employees, it's going to be a problem. And AI is only going to make that worse because gone are the days where you could have personalized relationships with every single UR person on the other side at the carrier. Now you're just doing a lot more of automation, and so you just better expect it that your notation just better be best in class. That is the biggest challenge I see in our business on the RCM side.
I think the only thing I would add to that is that on the other side of the equation, there are a number of AI products now coming to market to support note-taking and improve documentation quality on the provider side. I think there's going to be a really interesting race to the top there to see who's able to really create something that, I guess the way I'm thinking about it is that as of now, at least to my understanding, this is not my area of expertise, but the AI-generated content is still distinguishable from human-generated content. That's not going to be true forever, but the AI bots out there today are still able to be detected as non-human content by some screens. And so it's going to be the blend of how do you use AI to make yourself more efficient and make sure that all the charts are tailored and customized, but also keep enough human elements so that you're demonstrating you're actually providing the care and not just having a bot write the charts.
Yeah, 100%.
And for autism, I would say, some of the newer applications that are coming online, the savings that you get in terms of time of documentation. It takes a lot of time to document what happens in a 3 or 4 hour period when you're running a bunch of programs. And it's all filtered through, a technician and their understanding, their vocabulary, and so on. And so when you have, an AI program that's working off of what has actually happened in the session and then doing a narrative on that, based on that, not only is that a time saver, but it's actually more accurate. So that's exciting.
I wanted to shift. I think it would be useful to get into the RCM dashboard. Greg, can you just talk about what an RCM dashboard is and why you think this matters?
Yeah, so this is something that's been really important to us from the very beginning at Prosperity, and it's something that I think really should be important to all the providers in the room and all the providers that are around the country. Ultimately, your RCM data touches and captures a lot of different aspects of your organization. There's clinical data in there through the authorizations, there's admissions data in there through the VOBs, there's financial data in there in the charges and payments, also the patient balances. So there's a lot of really valuable data. And the more you can add on to that data, if you can bring in information from your CRM, for example, or from your EMR, and you can all, you sort of merge that all into one place, you start to be able to drive really powerful insights into how your organization is operating, how your organization is performing, both for the leadership team, the investors, and also for the patients. And so when you think about these dashboards, the way I really, they are RCM dashboards, but I think that it's really important to understand that they're not, obviously there is a place for dashboards for the RCM team, productivity analysis, all of that type of stuff. But when I think about this topic, I'm really focused on this more holistic, performance management oriented, how do you use this data to drive success for the organization?
Mm-hmm. Any thoughts on key metrics? What's the most important metric? I mean, I'd love to get a quick kind of thoughts from everybody.
I'd love just to kind of add on to what Greg was saying about that, just to see how it works in like an operational perspective. So if you think about the front end of your business, if you try and figure out how the patient came to you, you're probably trying to ask that question when they first do that intake. Did you call Google My Business? Was it word of mouth? Did you come through digital marketing? Your call center most likely has some sort of attribution data to show you where they came from. That's like the real focus. I think what you don't think about is the back end of your system giving you, are you uploading the codes into the back end so that you can see what you're getting decline codes for? What is your team doing that your RCM is not getting the actual cash flow for? That's a big overlooked element that Greg's team is able to kind of hone in on. And what it does is it shows you where the operational inefficiencies are on your team. What is the reason why you're getting decline for that person in detox or in mental health? Are they not, high enough on their cows, their CWAS, their PAWS? What are the issues here? And so you'll see trends from actual therapists if you actually have that data. It's insightful. It's not something that you kind of come to this intuitive conclusion on. I definitely didn't, But once you build a dashboard on the back end, you're able to really see that. So that's kind of my one thought about kind of what he said. There's just extreme value in having a dashboard. I can't emphasize that enough.
James, what are for you, what are the key metrics for autism?
Well, I think, basically having an understanding. First of all, when was the last time you did a contract or had a contract discussion, right? When was the last time you had a rate discussion? And if you're going to have a rate discussion, how are you going to go to the payer and ask for a rate increase without having any kind of context or any kind of data? That's really where it comes into, I think. And so are you tracking first of all, do you know what the policies are within your state or with your payer around denials, appeals, timelines, all those things? And is your back office cognizant of those things? Are they actually tracking them? Are there any cases that aren't being followed up on, those kinds of things? So really having kind of a holistic, I really focus on the quality stuff and the clinical stuff, but I think it's really important that on the back end that you're really paying attention to, how things are working financially and operationally.
Scott, any thoughts?
I love RCM dashboards. I think it's the greatest thing ever. However, using it for all these various purposes that were mentioned, yes, but you definitely have to be purpose-driven Like, what is your purpose for using this in a technology? So I think a good way to look at RCM in a dashboards would be, my purpose, if I was an operator, would be, how do I take out subjectivity out of answering the question, did I have a successful period? Whether it's a month, a quarter, a year, past 3 years, right? So you want it to be objectivity based. So I think some good KPIs, if you look at like, ask yourself, how do I define RCM in a success? Then I would say 3 good pillars for that, right? You want to look at your charge in a penetration rate. So I want to bring that down. I want to simplify it. If I rendered 100 services in February, how many did I get paid? Everyone would love to think you're going to get all 100, but that's not realistic. You have denials, appeals, etc. So good benchmarks for anyone who cares, it's going to be charge penetration. You should at least aim to get 90% of your charges rendered or your services rendered within 90 days. So it's like a 90-90 rule, right? So 90% within the first 90 days from when you submitted the claim or the charge, whatever you call it. A second pillar, which is also a good one, which I know Harrison talked on, was repricing. So what is repricing? If you're out of network, if you're in SUD, mental health, commercial payer, you want to get at least 60% or higher priced on your claims. If you're beneath 60%, that's a good candidate to get that payment increase. And normally the payers that are like low-hanging fruit, super easy, Aetna, Cigna, once upon a time United, but that changed, right? But they're still repriceable. You have third-party companies out there that we work with, that we recommend, that just focus in on it. And I'm sure Prosperity does it as well. So you guys have a lot of options. So getting those out-of-network, low-paying claims repriced, that's low-hanging fruit. And again, Aetna, Cigna, United, and even UMR. Blues, if you have spare time and you want to try it, then go ahead, right? But it's fun. But it probably won't get you anywhere. And then the last thing I like to look at is, average days to pay, right? How quickly am I getting paid? And normally, if you're Medicaid, you're getting paid every 2 weeks, maybe 3 weeks. With when the federal funds went on that freeze, we had some clients in Colorado, and that Medicaid sent out an email saying, hey, you guys probably are not going to get paid, but they're supposed to release the funds, so we should. And these clients normally get $200,000 weekly drops. So it was a big deal, right? This was from the raise in Colorado Medicaid. So you definitely, going back to that third KPI, how long is it taking for us to get paid? You want to stay within that 30 to 40 calendar day mark from the date you submitted. Because a lot of people look at the RCM dashboards, they see the data, but there's so many variants in there, right? So if you want to calculate how long does it take to submit the claim, well, wait, is that from when we rendered the service? Is that from when we entered the claim in the system? Or is that from when we released it? So it's a lot of moving parts, but again, you have companies out there like Congress, Prosperity, that will know how to answer these questions and guide your cash flow in the right direction. Greg?
Yeah, I want to pick up on one of your themes, Scott, which is that it's very easy to get overwhelmed by data. There's an infinite number of metrics that you can calculate from revenue cycle data. And it's, in my view, sort of really important to focus in on actionable objectives, right? So when I think about RCM dashboards, I'm always asking myself the question, okay, what action am I going to take in my organization, or what action is my client going to take in their organization when they see this dashboard? So I'm a big fan personally of waterfall charts. For those of you who don't know what a waterfall chart is, it's basically like a long bar at the beginning, which is, for example, last month's cash collections, and then you have a bar that goes down, that's one factor, and another bar that goes up, that's another factor, and you sort of have this bridge, and eventually you get to the end, which is this month's cash collections. So I always like to ask myself, I'm a big fan of that type of chart, and I like to think about, in the case of cash collections, the example that I just gave, okay, so last month I had $1 million. This month, I had X amount less because my payer mix changed. So what does that tell me? What action am I going to take based on my payer mix changing? Well, I can go to my marketing team and I can talk to them about, hey, how's your BD targeting your referral sources, what's coming in through the Google channel, et cetera, to try and retarget your payer mix to be more favorable. Then the next bar might be your cash collections went up a little bit because your level of care mix changed. Okay, so what am I going to do with that information? Well, I'm going to talk to my clinical team about how did we keep folks longer at a higher level of care? Or what is our step-down process looking like that's allowing us to improve revenue for that reason? And you sort of go through all the various factors that influence how cash changes from one month to the next. And you understand not just the numbers, not just what does the data say on the page, so you explain what happened in the rearview mirror, but then you can go take that to your team and actually make changes in your operation to maximize your performance going forward based on that information.
I was curious, like just to flip the question, are there things that are red flags or warning signs that people should, denial rates, or more nuanced stuff that's going to show up in a RCM dashboard? Do you think it will, that providers should say, uh-oh, so we've got to change something?
I mean, I definitely think denial rates is a good one. I mean, there's a handful of sort of key metrics that are that we think of as being major red flags, obvious red flags. We talk about the clean claim rate. What a clean claim rate is, for those who don't know, is basically the claim was submitted with all of the boxes filled out that need to be filled out in order for the payer to accept it. So with modern technology and experienced billers, your clean claim rate should be approximately 100%, 99.5%, something like that. So if you start to see the clean claim rate creeping up, that is an obvious red flag at the very front end of the process. And as you move through the process, denial rate's another great one. Scott sort of gave the 90-90 rule, and that's another great red flag, where if you start to see that your collections as a percentage of charges is going down periodic, over time, that's an obvious one as well. But I think that there's, at each level of the, or each phase of the process, there sort of are their own, each phase has its own unique set of like blinking red lights, so to speak.
Yeah, and I hate to do this, but I keep switching the topic. But Harrison, I just want to pick your brain because you're up here. In the world of CPA, and I'm kind of speaking outside of my world because I'm not an operator, but in the world of like CPA and saying, how do we reduce that? And if you think about the channels, right? So you have like alumni, you have really digital, you can have continuum of care, et cetera, and then pull in that RCM, because what I was told by my clients is that, alumni is the cheapest, continued care, et cetera, and actually BDs, right? Yeah. But if you just say, all right, I want to get all alumni heavy and I guess whatever BD heavy, the cheaper ones, how would you, for your organization, use the RCM in a dashboard to pull in the other side, like, what Greg said, the payer mix, because sometimes that could affect the payer mix coming in.
It does, yeah. I think there's so many different ingredients that kind of go into the model, and Greg talked a lot about it, but it's easier said than done. I was kind of like the thought going through my head. Hey, can I navigate all this and then make sure that the clinicians do their job and we can kind of go through it all. I think on the BD side, what we've been seeing recently, specifically with some of the exchange plans, is the insurance companies aren't reimbursing that full length of stay like they used to, because what you're seeing is an individual probably leave care at another treatment center, relapse, and then come back in. They're telling you that they've been sober, or they were sober for a long time and they relapsed and they kind of need to come back into care. Then I get on the phone with Ambetter, and Ambetter's like, yeah, this person was in a treatment center down the street. They, left for 3 days, and we're not going to authorize detox. We're now treating at detox, so the cost to treat is clearly higher. And then, you're only getting authorized 14 days for res. You have a kind of moral obligation to make sure that you do the best for that patient, but the carrier doesn't really care, to be honest with you, as much, if they're a frequent flyer, as they call them. So I think there's some of those elements that you clearly kind of take into account. I'll try and steer back a little bit from the RCM side. There's a lot of different elements of how you bring your patients in. The best thing is obviously if you can have just the lowest marketing expense. Like I've gone through the full cycle of being digital advertising only in our business, and then ultimately you really want to be a community health partner. But it just depends on your specific product. You know, if you're out of network, small, like we talked about, you know, 6 or 12 beds in California, and that's kind of the business that you want to build, you kind of have to understand how your RCM works on the back end for that. If you're going to be an in-network community health partner, you really just want organic channels, and you kind of open your doors and you don't look at that as much. You focus more on the product. RCM kind of just gives you the insights for how this is going to work. You know, just to kind of maybe bring it full circle back to you, Harry, was a red flag, which is I think when I see claims not paying the entire amount, like if there was 100 Aetna claims and we're only getting 50 of them paid and the other 50 are outstanding, even though they're clean, I probably know I'm in the beginning of a medical records request or an SIU investigation or something's going on. That is scary. And then you got to get ahead of it, because if you get ahead of it, it's better than SIU kind of calling us at that point in time. So as an operator, those are one of the big red flags that I see, because that's when you know that you're probably in a cash flow tightening position. And so it's just better to get ahead of it than kind of be behind it, is what I would say.
Thank you. I wanted to open it up for some questions. If people have, there's a microphone, there should be a microphone going around the room. If people have, just raise your hand, and happy to call on people. While we're waiting for a first question, I'm just going to throw out a couple of things. One was in doing billing internally versus outsourcing. How do you think about that decision? I sometimes hear clients say, I've seen cases where it was the worst decision people made to take it in-house, and clients who say that was the moment of transition to really changing things for the better. So I'm curious how you think about that.
So I think at scale, there's clearly an economic benefit to it. You clearly have more control. You have to manage an additional division, so you have to have a key leader to be able to oversee that team. So it's a different part than just running the product. I think we have in-house, we have out-house, to be honest with you. So we use Zealy for some of our billing, and then we have some of our billing internally. I think it provides you more knowledge for what's going on. The benefit of using outside individuals is the fact that they service a larger spectrum than what you currently service. So you only know what you know, which is internal. When you have someone that you outsource to, they've got a ton of clients. And so they're able to give you reference of what each of those individual clients is going through. That's a really great benefit of outsourcing some of your billing. The downside to it is it's not your own team, so they're not going to work 40, 50 hours the entire time. So just being mindful of that. When it happens, there are issues that happen to that specific billing team. Do they lose a lot of their personnel? They don't tell you because they don't want to be upfront about it, and then all of a sudden all your claims aren't getting processed. So if you're on top of it, it's great. I think that there's pros and cons to all of it. I would say at scale, you probably definitely need an internal team, to some extent. I don't know if I would completely, just eliminate, talking to other individuals, just because that's where I get most of my information, to be honest with you. What is somebody else going through? And that's a very, very big value add. That's what a lot of these guys up here provide, is that context.
That's a great point. Any other thoughts on in-source versus out?
Yeah, I think the number one thing we should go back to is our purpose. Why do we want to keep it outsourced versus why do we want to bring it in-house? It's, as I heard Harrison really touched on it, it's learning a new business. It's a new vertical within your organization that you have to learn. So if you're not willing to be educated on it, if you're not willing to have awareness around it, accountability around it, then outsource it. And on the flip side of that, if your only reason to bring it in-house is because you want it cheaper, then just really negotiate with your RCM company for a cheaper rate, right? It's going to be a better outcome. So that's my 2 cents.
Yeah, we have a question. I thought somebody, does anyone have a question? Raise your hand, don't be shy. But if no one has a question, I've got lots of questions. So my next question, I want to talk about lifetime value of a client. I want to hear how you think about it. Scott, you picked up on something that I think is very important, which is, what we see both in the autism side and in substance use and mental health is the long-term ability, the longer you can actually be engaged with a client, the more you have efficacy to help them to actually have therapeutic benefit. But how do you think about it in terms of long-term value? I'd love to hear your thoughts about what that looks like.
Well, in the world of RCM, it really ties back to the CPA, right? Like cost per admit. most operators, they're equating the LTV with how much does it cost, right? Because then that is going to allow them to strategically pull on levers when looking at their intake channels, right? Business development, all that. From an RCM standpoint, though, if we absolutely want to look at the admissions and make sure that if the client has the same policy and it's being carried forward, right, in readmissions or movement even within that continuum of care, that there's consistency in payment, based on the service line. So that would be the key component from the RCM lens. Greg, do you have a different?
Yeah, I have some thoughts about that. Before I get to those, I just want to quickly come back to the previous question on in-source versus outsourced. As the third-party outsourced company on the stage here, I want to express my agreement with the point of view that there are different solutions that are right for different companies at different times in their development. And I definitely agree with Harrison, a big value proposition of even at scale, staying engaged with an outsourced partner is broader industry context, broader network of payer relationships, all of that type of stuff. And another sort of variable that we have increasingly seen in our business is folks who are not exactly, I think what you were describing, Harrison, although correct me if I'm wrong, is that you've got some locations with Zealy and some locations in-house. What some of our clients have done as they've gotten to that kind of scale is that they've taken certain functions in-house and left certain functions outsourced with us. So that's another way that you can partner with a third-party provider. Maybe somebody's doing your VOBs, but you're doing your own authorizations. And that's increasingly something that we're seeing folks do as they scale up. On the topic of the lifetime value of the patient, though, I think one of the things that is also really important is to think about the cost to treat. So we think about lifetime value of patients very differently for our inpatient partners than for our PHP IOP, and again, differently for our outpatient, general outpatient providers. Because obviously, if you're providing 24/7 nursing, that's an expense that you don't have if you are doing 3 hours of IOP. So we think about really those three buckets of total value of the patient. So we're, I think, sort of similar to what Scott was saying. We think about the top line value of the patient, but we also want to work with our customers to think about the bottom line value of the patient. In other words, what's the revenue you're going to generate after all the expenses to acquire and treat that person?
Yeah, I think, in terms of autism, it is a lifelong disorder. However, you can risk adjust for the severity. And I think it's important when, at the point of diagnosis, you have indicators where you can actually say, this is a person who's going to need care lifelong, who's going to need it long term, versus someone who, after 2 years of intensive care, is going to be able to be mainstreamed, is going to be really kind of, not cured certainly, but they're going to be much more functional. So I think it's really important that happen. I think also one of the problems we have with insurance is that people change coverages. So when you're talking about a lifelong or you're talking about something long-term, what they'll say is, well, maybe a family is with us on average 2.5 years, and so we'll be involved with them to then. But then they go on to another insurer, and we don't see the benefits of that. I think that's a very cynical view, but I think it's also partly true.
Yeah, James, you kind of took the words out of my mouth. That's like the thing you deal with. You think about LTV, that's like the classic, like, hey, I'm going to come in, I'm going to look at my CPA, what's the LTV of this patient, We generate $30K in revenue, they're going to have recidivism, they're going to come back to us 3 or 4 times, it's $120K. It's a flawed approach, just to be honest with you. Mm-hmm. Patients change insurance so often. I think that's probably a decade ago was what that approach was appropriate, because you had so many individuals who were going through the opioid epidemic and they were on their parents' insurance and their insurance for their parents was stable. That's not the major kind of demographic that we're all treating today. So we see patients flip their insurance like 3 times, sometimes in 3 months on exchange plans. It happens all the time. So LTV is definitely interesting. I think the holistic and way I would think about LTV moving forward is, how was their experience at our facility? Did they have a good experience? Was the product best in class? because word of mouth referrals are the best marketing source you could ever get. And if you think about it that way, you're set up for long-term success. That's just my personal opinion. I don't know if everybody agrees with it, but I think that's kind of where I've come to over a decade of kind of operating in the space.
Yeah, I just want to add, I'm struck, the question about lifetime value could lead to cynical, as you're alluding, could lead to cynical questions about just how do you maximize, how do you squeeze every last dollar here. But I think one of the lessons for me of spending 30 years in this space has been the road to success as a provider leads through quality, and quality is driven by strategic decisions where you're listening and paying attention to what your clients' needs are, whether that's moving towards more medical and professional services, whether it's listening. I have one client in the autism space who developed a whole line of education, of support groups, and things that where they're not billing insurance at all, but that the parents and families wanted. It's really, moving, but also incredible. It really demonstrates sort of what's the strategic perspective of. So I would add that to the conversation. Yeah. Last chance, really, this is going to be your last chance for any questions before I'm going to throw it back to. I don't see any hands. So I'm okay. All right, going once, going twice. I want to give everybody. Maybe I'll start at the far end, Greg, and give everybody a chance to give a final thought of a key takeaway that you would want people here today to think about on this topic, in terms of revenue cycle going forward, how to improve their operations.
Yeah, if it sounds like I've got a theme today, I do. I would say that my answer to that question is don't think of revenue cycle as sort of like the ugly stepchild of your operation. The revenue cycle, it's not just about where's my money. It's not just about sort of what's in the bank, can you make payroll. It's really an incredibly intersectional point in your business. And if you really sort of understand the revenue cycle and understand how it connects to other things in your operation, there's incredible amount of power to drive performance improvement, both from, all over the map, from an admissions and marketing perspective, from a service delivery perspective, from a readmission and alumni engagement perspective, and also obviously from a financial performance perspective. So there's a lot of powerful data in your revenue cycle, and there's a lot of connectivity with other aspects of your organization. Don't miss that opportunity.
Awesome. I think I'm going to go back to purpose-driven, right? If as an operator, your purpose is to get your clients safely on that journey to healthy, however that is actually defined, and also to do it with as many lives as possible, then your organization, your company is the vehicle, and RCM is going to be the gas. And you're not going to get to your destination if you keep running out of gas, or those friction points that you keep slowing down because you have to stop at different gas stations, right, which could be different third parties, all that. So, and also lastly, let's not be ashamed to focus on RCM, because we can save lives as operators, but also get the energy, the fuel, in order to do that. So that would be a key takeaway from my perspective.
Thank you. Okay.
I think in the autism space, I think we're moving from a more is better to a better is better kind of a model. I think there's a belief that every child between the ages of 3 and 5 deserves to have 40 hours a week of ABA. Not only is that expensive, but it's probably over-prescribing. And there's some more literature that's coming out that basically says you can do a lot more with fewer hours. I hope that doesn't lead to insurance companies saying everybody can have fewer hours and that's okay. But if you're a practice that has access to specialty docs who can help with treating comorbidities, you're sharing information with them, they're making decisions about medication, they're making decisions about intervention and keeping tabs. All those things are going to be more important than I'm focusing as an ABA provider on this child, sometimes even to the exclusion of the parents, unfortunately. I think the reimbursement continuum on the slide, basically, there are a couple of instances I know where value-based care is being done. It's really kind of a bonusing kind of a situation right now. It has the potential for going a lot further than that, but that's going to mean that you're dealing with the medical issues, you're dealing with the behavioral issues, and you know, it's very difficult as a payer to discriminate between a 20, 30, or 40-hour-a-week case. There really isn't any kind of algorithm for that. So, you know, if you can establish an arrangement, an alternative arrangement, what that means is you have a guaranteed income per patient. They have a guaranteed income. The payer doesn't have to worry about denials. They don't have to worry about appeals and staffing those things and the time that takes, and reviewing treatment plans to the same extent. So I think that is the way I think that things are going to be going, but it's a slow start.
I would say on the RCM side, my thought would be, if you think about your product as a car, the engine is kind of the marketing, the admissions team. The car is where you sit, that's the actual product, that's the service you're providing. RCM is the lights. If you don't have your lights on, you're driving at night, you're gonna crash. And that's really the value of RCM. It kind of tells you where you're going, it gives you insights to how to run the business, you can kind of circle back. If you don't have your lights on inside or outside, you're not knowing where you're going, you're kind of just driving aimlessly in a sense. So that's the one kind of learning lesson I've seen so far from RCM.
Thank you. So we're at our time. I'll just close by saying I think this topic is such an important topic. We had to move really quickly through a lot. I really want to thank the panelists. I think I thought there was a lot of really great stuff here today. Some great ideas, important ideas on what I think should be an anxiety-producing topic in your business in an anxiety-producing moment. But hopefully this panel gave some grist for the mill of where to go next. And grateful to everybody for coming today. Thank you so much.